other programs as well that affect people who are on Medicaid, but also on other means-tested welfare programs as well, such as food stamps. So, not just through the more narrow prism of Medicaid. Previous to working for Governor Walker, I was at the Centers for Medicare and Medicaid Services for 7 years under Governor Bush, number 43. There I was the lead federal negotiator on a number of innovative waivers for Indiana, for example, to create the power accounts, negotiated waivers for Florida, dealt with all of the waivers in the wake of Katrina and Rita, helped states again to assist individuals in need. Also developed what was called the Global Commitment Waiver for Vermont. So I'm very familiar with that, having helped to design it, can tell you the advantages and disadvantages of that, the risks and the advantages. And previous to going back into federal service, I had been on the Senate Finance Committee as a professional staff member and helped to both on welfare reform and in the Balanced Budget Act in 1997 to help create the Children's Health Insurance Program, which you all know as Our Kids Here. But I've always reflected as to why CHIP was so successful and popular, and why is the ACA so controversial and divisive in many ways. So thank you for having us here. Back to Rich.
So before we get into our presentation, I did want to address the cost issue very briefly, because I know that's been a focus of the conversation. I did want to let you know that we bid a 19-month bid. We asked that question and were provided direction that yes, a 19-month bid is appropriate. And so we'll get into this in the 4 questions too, but we break out our costs as $1 million in the first 4 months. We want to put a lot on the front end because we're going to give you a robust audit. And then we do not plan on phoning it in after those first 4 months. We plan on a robust level of support for implementation. And there's $1.2 million for 15 months for implementation, all the way through December 31st of 2016. So I just wanted to address that before Dennis begins.
Thank you. What we would like to do really is talk about what we call our 5 pillars, and I'll go through them. First pillar being a healthy and prosperous Arkansas. Second, the state budget. Third, personal responsibility. Fourth, accountability to the taxpayer. And fifth, keeping families together. We go back through each one of these and to explain sort of what our thinking behind this is. As you have heard, we've all had extensive experience in healthcare programs, Medicaid in particular. The traditional approach to Medicaid, though, when you need budget savings, are cut eligibility, cut provider payments, or cut services. In the long run, none of those really work. So what we have really been working on for years is how do you really change the system? Who is on Medicaid, who should be on Medicaid, the different populations in Medicaid. Medicaid is not a program, it's several programs. It serves several different, very distinct populations. When you're talking about the healthy moms and kids populations, you are targeting interventions specifically towards them. And that is very different than dealing with an individual with a disability, very different from our seniors who rely on Medicaid typically for their long-term care. But we will talk about the healthy and prosperous Arkansas because this is not just about health care. As important as that is, the health status of an individual affects the rest of their lives as well. And so again, what we're looking for, focus on the different populations, the working age, non-disabled individuals. We ought to be talking and thinking about how do we get them healthy again so they're back fully engaged in the workforce, and our taxpayers again, that they're helping to pull the wagon. It's very different for the individuals with disabilities who may have very complex medical needs, may rely on the Medicaid program for their entire life. But there again, it's not just about health care. It's about freedom and liberty, how an individual wants to live their life in the community, fully engaged in their community. For a senior citizen, for them, again, as important as health care is, it's not just about health care. It's about how they want to spend their golden years taking care of their grandchildren and playing with them and being a part of their lives. Secondly, the state budget. If you don't have Medicaid under control, you don't have your entire budget under control. Every state, including Arkansas, increasingly a greater and greater share of state spending on Medicaid. So if you are continuing to, your Medicaid costs are rising faster than the revenue that is coming into your state, which is where the situation most states are in, then you are funding Medicaid by taking money away from other state priorities. You can't fund pre-K. You can't fund your infrastructure. You cannot fund investments that you want to make in returning taxpayers some of their hard-earned dollars. So as long as Medicaid is growing faster than the rest, and faster than your revenue, you really don't have it under control. So one important, very distinct way of the way we look at this very important initiative is to specifically define that percentage of state spending 5 years from now should not be any greater than what it is today. And state spending, the general fund revenue, should not increase faster than overall revenue coming to the state. So again, a very specific benchmark that should be measured against. The third pillar of personal responsibility. And this is a particular perspective of talking to many, many people who are actually on the Medicaid program. First, and again, looking at the different populations, distinct populations that we serve. First thing to keep in mind, many people are on Medicaid because something bad happened to them. They lost their job. They had a very bad illness to where they could no longer work. There was a divorce. There was something that happened to another family member that perhaps you have left your higher paying job to take care of your ill mother. So our focus again is on the system that Washington has created, states have had to implement, and trying to reverse that into say Medicaid should be temporary for individuals who are able-bodied. They may need it, but they should need it for a very short period of time. And their objective is to get back to work as quickly as possible, and we should be designing a program to help them do that. We already know, not just in Arkansas, but across the country, Medicaid eligibility is sensitive to the economic times. So we already know today, before the expansion took place, Medicaid enrollment in Arkansas was 10 to 15% higher than its historical trends. So why are people coming on Medicaid and staying? Again, needed for a temporary period of time, but you should be moving off of Medicaid over time. So what can we do to help with that? First is engage the Medicaid enrollees themselves. We expect little or nothing of people who are actually on Medicaid. There are things that we need to raise our expectations of people who are on Medicaid. Doing the little things that add up. Taking a generic drug rather than a brand name drug. Actually following doctor's orders. Over the years, having discussions about dentists. A major problem is lack of access to oral health among the dental community. And some folks will say, well, it's all about the rates. Well, talking to dentists, no, it's not all about the rates. It's about being able to follow a treatment plan. It's being able to engage that client to come back for their treatment. And they're saying, well, they're not doing that, so I'm not going to be successful. So again, it's ways to engage people who are on Medicaid in common sense ways, to have the expectation of the neighbor next door who is in the workforce, who is paying a much greater share of their cost of healthcare premiums, co-payments, et cetera. And again, looking this to some extent as an issue of equity. not about health care. Fourth, the accountability to the taxpayer. One of the parts of the request for proposal outstanding was an audit. That's exactly where you should start. You can't know where you're going if you don't know where you're at today. Doing an audit is simply setting a baseline, saying where are things existing today. You have a new administration down here in Governor Hutchinson. The first thing that we did becoming a new administration is say, where are we at? How did we get here? And only from then are you informed well enough to break down the spending by Medicaid eligibility group, again, separating things out, disaggregating the data. You get an annual report, you get a budget report out of the departments, and you see great big numbers, $5.3 billion in 2014 for the entire Medicaid program, 3.9 of that coming from the federal government, $880 million in general fund. But what does that mean? Where is the money actually going? Is it being spent correctly, etc.? The accountability to the taxpayer, you have to assure your constituents that every dime that is being spent efficiently and effectively. Program integrity is something I have worked on for years. One of the first things we did with Governor Walker was to appoint an independent inspector general. And again, at the time we were told, well, there's no fraud in the Medicaid program, there's no recipient fraud. Well, looking back at the latest numbers, more than 1,000 people have been taken off the food stamp program because they were defrauding the federal government. And states have the responsibility to do that. Your state agencies administer the food stamp program. So if there's a high error rate, it's because the agency is not doing its job appropriately. And again, this is where there's an intersection between healthcare programs and Medicaid and other human services programs. Medicaid doesn't stand out there by itself. All too often we talk about Medicaid as being completely separate and apart from the rest of the system. I think that's a mistaken approach to it. It is part of a larger system. And on the the intersection between healthcare and other welfare programs, taking work requirements as an example. And I know there's been a lot of buzz about work requirements in Medicaid. But when you look at the Medicaid population of those, again, we're talking about able-bodied, non-disabled individuals between the ages of 18 and 50. A, there are already work requirements in part of the food stamp program. B, the most states, more than 30 states, and Arkansas being one of them, has actually gotten a waiver from the federal government not to require people to go to work. So again, if your concern is about people on Medicaid and work requirements, you can fix that through the food stamp program rather than through the Medicaid program. You wouldn't want to operate two different work programs anyway, right? That would simply be duplicating the cost. But the key is to do an audit of the system.
Sir, if you just, let me make sure I heard what you said, because I want to make sure that I heard what you said. Now, let me play back what I just heard. You're saying the federal government currently has work requirements for some of these programs. I think you mentioned food stamps, and that Arkansas has actually gotten a waiver from that requirement?
Yes, sir. This happened, it generally happened during the recession. And again, Arkansas is not alone. More than 30 states have done it. And the caseload increased so dramatically. And the states, they do not fund the food stamp benefit. The benefit itself is 100% federal funding. But the administration part of food stamps is shared by the states. So many states abandoned work requirements because of the administrative cost for them in running a work program. But states, now that we're coming out of the recession, more and more states have given the waivers up. Again, this is something we did in Wisconsin to say, look, we need to send a very clear message. The real pathway off of Medicaid for the non-disabled population is work. Program integrity, again, is a very key part of this. And it's not dramatic. It's not one thing. It's 36 things that you have to do. I always say you have to do the laundry. And that's what program integrity is. It's just a long, hard slog of saying, are the edits on the system being done? Are they being done correctly? Again, many states in the transition over, all states in fact, the transition into the Affordable Care Act stopped doing Medicaid redeterminations on eligibility. So today there are people on Medicaid whose income has increased above the Medicaid eligibility levels, but they have stayed on the roll simply because the state has not done those redeterminations. Those redeterminations, yes, it costs money to do that. It costs money to be able to go through the system, to identify the people, and to walk them through the process of being able to say, again, Medicaid was temporary for you. You are no longer qualified and no longer on the rolls. The last pillar, the fifth pillar, is keeping families together. Again, over the years, I've seen these different programs multiply, increase, and we keep treating them as separate programs. It is not unusual to say one child is on Medicaid, one child is on CHIP, one parent has no insurance whatsoever, and one is on an employer plan. Again, I think the approach is not the traditional approach that you often hear, but should be an objective goal in itself of keeping families together. And if you also think about it, every time by keeping each member of the family in separate plans, you are paying 4 or 5 different times for that individual, when it's a heck of a lot cheaper to buy one policy that covers the entire family in family coverage. So again, I think there are things that, again, when you're looking at the working population, most families, most individuals in Arkansas get coverage through their employer, for which they are paying a premium, they're paying cost sharing, and have a significant amount of personal responsibility associated with that. So helping, again, the Our Kids program goes above 200% of the federal poverty level. Again, ways of thinking about keeping that family together. And if your eligibility does change because you've had an increase or a decrease in your earnings, you don't lose your plan. Right now, again, as people do not live their lives according to the rules that we lay out in the Federal Register. When our program requirements say if you earn $10 a month too much, or $10 a month too little, we're going to take you out of that program and we're going to put you in this program. You may have lost your doctor, you may have lost the trusted healthcare professionals that you have depended upon because your income changed by $10. I think there are smarter ways of dealing with that. I think on that note, we just mentioned, again, I mentioned at the beginning of my remarks, negotiating the global commitment waiver that was out there, that there, in fact, I think is probably a better pathway that states should be thinking about. Ironically, a provision within the Affordable Care Act called Section 1332, which in many respects is the most anti-Obamacare provision in the entire act, which says, forget all the rules. You don't have to do the individual mandate. You don't have to do the employer mandate. You don't have to do this. You don't have to do that through a 1332 waiver. And it's a way of being able to combine funding streams. In Medicaid waivers, and I would have loved to have been able to approve what I truly consider to be a block grant. But you can't do that within 1115 waiver. You can't do that within, and you're only dealing with one program. In 1332s, you can deal with the entire, any federal program dealing with the financing of healthcare. So it's a tremendous opportunity for states. I know that you all have thought some about 1332s, which puts you ahead of other states, and I congratulate you on that. Let me stop there and return Rich.
Thank you. I wanted to supplement what Dennis has said by drawing your attention to page 25 on our presentation. If you don't get there, I can walk you through it. But really what page 25 is a graphic which...
Hang on, are you talking about the RFP or do you have a handout?
We don't have a separate handout. It's page 25 of our proposal.
Okay.
And it is a graphic which shows a little bit of an organizational chart functionally.
Members, that's in book one. If you're looking for it, it's the next to last one, book one. Would you just give us a look? You can see we got a bunch
Sure.
of stuff.
Absolutely. It's a graphic that is in the form of an organizational chart, but it's a functional chart. Blue blocks with 5 columns. You're good? Okay. All right. So the point I want to make with this is that we believe the public consulting group and Ken Long Aldridge team brings a combination of thought leadership and then behind that what we call the big engine of support for all the kinds of things that a Medicaid program does. Medicaid is a big, complex enterprise, and PCG specializes in that. We are a public sector firm, we're focused on that, and what this really shows you is within our health unit, there's 5 major categories that we look at within the Medicaid program. And I think, I don't want to spend a lot of time going through the individual elements, but the point I want to make from a big picture is that many of these columns are about program integrity. They're about audit. They're about making sure that the right claims are being paid, that the right eligibility is being determined, and that a program is working as efficiently as it should be. We are the operations engine to bring behind the thought leadership of the McKenna Long Aldridge team. And what I want to do a little bit of in this section is to apply some thoughts about how this structure can actually help Arkansas. I know you're not looking for big general ideas that don't go anywhere. We know that you're looking for action items. You're looking for specific items with savings attached to them that are going to further program efficiency. So if you were to ask us, what are some areas of specific focus for Arkansas? We would certainly name the eligibility and enrollment framework as being a big area of focus. I personally was eligibility director in Wisconsin for the Medicaid program. And eligibility actually goes beyond Medicaid. It includes eligibility for the SNAP program, which is food stamps, and child care services. I was Dennis's eligibility director. And what I can tell you is that the hard slog that Dennis described with the system audits, if those things aren't working, you're wasting money if those things aren't working. So that's a very important critical area for us to focus on. Second, I would suggest some review of the Payment Improvement Initiative. There's been a big investment in Arkansas of payment reform. You hear this as a buzzword, payment reform. The whole point of payment reform is to give different incentives for care, is to give different incentives for the way healthcare is delivered and to make healthcare better because you're doing that. And so we think there has to be some review as, has this big investment in payment reform generated those kinds of improvements in care or not? That's a big thing we have to answer. Certainly the long-term care programs need to be looked at. This is where most of the money is spent in Arkansas. There are different kinds of programs within long-term care. There's programs where it's more focused on personal care outside of an institution, consumer-directed care. The providers get very small and individualized. You have to have quality control over that, or you're going to be wasting a lot of money. That's definitely going to be an area that we're going to want to focus on as part of all this. We actually have, because we are present in Arkansas a lot and have had a lot of experience and exposure to the programs here, we have looked at some very specific ideas that we already are prepared to say would save Arkansas specific money. Right now, I can tell you that you're paying too much or more than you have to on claim types. They're called crossover claims, and that's a claim for a person who is eligible for both Medicaid and Medicare together. They're eligible for both those programs. Right now, you're paying up to the Medicare rate. You don't have to do that. You're choosing to do that. That's an area where you could save significant state money.
Can you give some sort of ballpark estimate of what that change would result in?
I can tell you that these three ideas I'm going to tell you together are worth an aggregate state savings of $35 million.
And is that at various match rates, depending on its Medicaid or Medicare? What
this is the state portion.
Correct, but I guess what I'm saying is it's somewhere between 3 times that or so. Because
Correct, right.
Total savings.
Right.
And I guess what I also ask you on those savings, is the net effect of that just really reducing dollars going to providers, or how is that?
On the crossover claims, the answer to that is yes. The two other ideas are different.
Okay.
I'll walk you through those.
Thank you.
The second.
We got another question. Representative Murdoch, you recognize.
Thank you, Chairman. I think he's fixing to go there. I was seeing, you were saying 35 million. Is this just some administrative change that can happen how we do it with those dual eligibles that you're talking about for those different programs? But you're fixing to walk us through it to tell us, right? Okay.
Right. The crossover claim is specifically something that can be accomplished through a change to your Medicaid state plan. It does not require a waiver. So it is an administrative change that can be made.
Thank you.
If I could also add, most states have already adopted this provision. So Arkansas is an outlier state for already not having adopted it.
The other area is an asset verification system. So what that means is for the portion of the Medicaid program where there's long-term care services involved, part of the eligibility is to measure the assets that a person has to see what capacity they have to pay. And right now, there's no system in place to verify what is reported in terms of assets. States are moving toward implementing methods to verify assets through financial institutions so that we're not just taking people's word for it, but if they have assets that they're not reporting, those are identified. We actually did implement this in Wisconsin and found that there were some people with considerable assets that were not reported. So that's another area of savings. And then the third is...
Okay, we got one question here real quick. Senator Chesterfield, you recognize.
Yes, define for me assets.
So it's cash on hand. It may be property that you own in excess of a minimum threshold that's allowed. So it's all those.
But if a person dies and leaves a nice home to someone who becomes medically fragile, the value of the property would then count against the individual's ability to secure health care.
Houses are exempt from the asset test up to, believe, the minimum of $500,000.
So that's what I'm trying to get at. I'm trying to get a definition of what you're talking about with assets. Or are we punishing people for having owned property? So homes are excluded up to $500,000.
Homes, income-producing property is excluded as well. Assets generally are liquid assets that are typically underreported.
So it's the cash and it's the savings and the investments.
Yes, Senator.
All right, thank you.
Representative Ferrari, you recognize for a question.
When you said that you're doing asset verification, are you talking for this project, or are you going to do asset verification for the whole Medicaid system, or asset verification still on the long-term care?
So the asset verification would be an eligibility check that would be implemented within the Medicaid program to verify what's being reported as when a person applies. So they may report, I have X amount of money in the bank.
For the whole Medicaid system, not just for long-term care?
There's only certain categories of eligibility in Medicaid that require an asset test.
Are we going to try to change that to where asset verification for the whole Medicaid system, even for this system we have?
only related to the long-term care population right now.
But can we change that?
I believe that is a provision that could be waived, so you could do it through a waiver, you could not do it through a state plan amendment.
Okay, but that is one of the plans that you're talking about, doing it for the whole Medicaid system.
I think, again, that if we will be bringing recommendations to you, we are going to say, to the best of our ability, we want to look at the way Medicaid is operating in Arkansas today and how we believe it can be improved. But all of these things, we understand our role as consultants and recommendations. It'll be the state's decision on whether or not to adopt any or all of these provisions. And again, I would say, going back to what we did in Governor Walker, we had to close a $450 million budget hole in the biennium. We came up with different ideas and plans, but as part of that, we came back to the legislature, a body in the legislature, every quarter, told them exactly what we were doing, exactly where the numbers were moving, and they could have told us to stop. That Smith, we don't like that recommendation, and we would overrule us. That didn't happen, but again, as we're approaching this project, we understand our job is to make recommendations to you. These are ultimately the decisions of the elected men and women who are on this side.
Senator Sanders, you're recognized for a question.
And I think that sort of clarification for what Mr. Farrar was asking, in what you're laying out, Mr. Albertoni, is you've identified 3 things in the existing program today, where we talked about the many issue, you talked about asset verification simply on the programs that require that today. So that's, you're not talking about applying that across the board in terms of this aggregate savings, correct?
Correct.
Okay, all right, so you sure. Thank you.
The third idea, are we good to go?
Yeah, press on, please.
The third idea is, right now, Arkansas is underclaiming for Medicaid school-based services. So certain children who are eligible for Medicaid, the families are eligible for Medicaid, and they may have in the schools services provided, health services related to individualized education plan they have in the school. Arkansas is simply underclaiming for those services right now. That's not going to get cut to anybody. That's going to be more federal money that you can bring in and claim. So that's to give you a taste of, we're prepared to bring very specific ideas to the table. We only succeed as a consulting firm if we are giving you a big return on your investment, and that's what we intend.